Thank you. Our guest speaker today is Heather Harlan. Ms. Harlan is a certified reciprocal prevention specialist and a Missouri Associate Alcohol and Drug Counselor. In her current work with the Health Promotion and Education Unit for the Columbia-Boone County Department of Health and Human Services, she focuses on community outreach for overdose response and adult mental health. Heather's experience also includes serving as an adult and adolescent drug alcohol counselor for many years at Phoenix programs. She also works with the University of Missouri Department of Psychiatry's Missouri Child Psychiatry Access Project, a grant-funded initiative to support pediatric providers in offering behavioral health treatment in primary care settings. Heather is also a volunteer family group facilitator for the National Alliance on Mental Illness. And in her spare time, she is a professional storyteller. The title of her talk today is "What are ACEs and Why Should We Care?" Please help me and join me in welcoming Heather Harlan.
Okay.
Very good.
Just take it from here and you'll advance them? All right.
Okay, so you ready for slides?
Yeah, thank you so much. It's a delight to be here. And let's just jump in and gallop through because I know you have a lot of questions and I want to leave a lot of time for questions.
Whoop, almost.
That's,
How about that?
That's good enough. I'm good with that. All right. Okay, so what are ACEs and why should we care? So first of all, there's going to be some difficult things to hear in this presentation. So if for some reason it's difficult for you, I'd like you to first just take care of yourself. If that means you turn off the sound or excuse yourself, that would be fine. It's just sort of a preliminary heads up. So our objectives today are that you, by the end of the presentation, you'll be able to define ACEs, that you will know your own ACE score. You'll understand the connection between ACEs and long-term health issues. You'll connect ACEs with the current overdose crisis, and you'll be motivated to share about ACEs with at least one other person. So I'm gonna, and before I even tell you what they are, some of you may know, but I'd like for you to, if you have a piece of paper, just kind of keep a tally mark. Those of you who are present, here's just a minute. Let's see. And I've got pencils there. Anybody need a pencil or a pen?
You got one.
Oh, the next room. That's one down.
Not yet.
What's one more?
One more. All right.
Here, Pastor, one more.
Well, so generous. All right.
And if I can have a clean copy,
Absolutely.
I'll scan that in and make sure it gets attached to the presentation.
Okay. All right. So those of you at home, if you want to keep a tally mark, that's fine, but just maybe just kind of keep track on your fingers or mentally. All right. So please note, all these questions pertain to events that may have happened to you before your 18th birthday. Right? Yeah, can I remember that? All right. Let's see. I need to move.
Get them out of the way.
The screen a little bit. Yeah.
There's the mouse. I think we can just
There you go. All right. Did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? And then you check yes or no. Did a parent or other adult in the household often or very often push, grab, slap, or throw something at you, or ever hit you so hard that you had marks or were injured? For your 18th birthday, did an adult or person at least 5 years older than you ever touch or fondle you, or have you touched their body in a sexual way, or attempt or actually have oral, anal, or vaginal intercourse with you? Did you often or very often feel that no one in your family loved you or thought you were important or special, or your family didn't look out for each other, feel close to each other, or support each other? Before your 18th birthday, did you often or very often feel that you didn't have enough to eat, had to wear dirty clothes, and had no one to protect you, or your parents were too drunk or high to take care of you or take you to the doctor if you needed it? Were your parents ever separated or divorced? Was your mother or stepmother often or very often pushed, grabbed, slapped, or had something thrown at her? Or sometimes, often or very often, kicked, bitten, hit with a fist, or hit with something hard? Or were you ever repeatedly hit over and over at least a few minutes or threatened with a gun or knife? Did you live with anyone who was a problem drinker or alcoholic or who used street drugs? Was a household member depressed or mentally ill, or did a household member attempt suicide? Did a household member go to prison? Now, for each yes that you answered, that adds a point. Now you know your ACE score, and it could be anywhere from 0 to 10. So what are ACEs? ACEs are adverse childhood experiences. Potentially traumatic events that can occur in childhood that can trigger toxic stress and change brain development and affect lifelong responses to other stressors that we may encounter. So here's sort of the biological underpinnings of this for us to understand. First of all, the brains that we're walking around with are really a 10,000-year-old model. I have a 2016 Honda Fit. I kind of know the technology that's in the hood, under the hood of when they made that car. So the technology that we're walking around, it's under the hood of our skulls, if you will, is a 10,000-year-old model. So in that setting, those models of brains worked very well. If there was a bear, let's say, or something that was threatening, and we would respond to that as humans, and flight or freeze, that sort of thing, we would take care of ourselves, the adrenaline would pump, the cortisol would pump through our systems, and we would be able to form quicker, hopefully to be able to, for the species to be able to survive. And then pretty quickly, all those chemicals in our body would subside. But we have a 10,000-year-old brain that's in a modern world. And the question is, what happens when the bear comes home from the bar every night? For children, especially. So our body and our brains, it's kind of like a car revving all the time. When we encounter levels of stress, our bodies are really made to handle that and sort of settle back down, if you will. But when traumatic events keep happening to children, it's sort of like an engine that gets stuck in revving mode. It's not created to do that. So adverse childhood experiences, ACEs. Why are they significant? ACEs are common. About 2/3 or 64% of adults have at least one ACE. ACEs cause adult onset of chronic disease and negative outcomes. I'll have a list of those later. It's important to remember ACEs generally don't occur alone. If you have one, there's an 87% chance that you will have two or more. It doesn't matter which of the 4 ACEs a person has, the harmful consequences are the same. The brain cannot distinguish one type of toxic stress from another. It's all toxic stress with the same impact. This is what was significant for me to learn as I understood this. People with higher ACE scores are usually physically or physiologically different than people with low ACE scores. Now, that to me, that's very significant. And the difference is it starts in the brain, but then with those chemicals, and what's different physically is those chemicals, the onslaught and the continuing circulation of those chemicals stuck in that mode, because again, we're talking about children that don't have adequate coping skills. Now, I will also tell you, every time I read those questions, it is uncomfortable for me just to read the questions on the survey. And we know there are children in our community that are dealing with 5, 6, 7, 8, 9, 10 of those every day, and no one's really supporting them. So, of course, they're going to be stuck in revving mode because no one's helping them. They don't have coping skills. Why are ACEs significant? The overriding finding from the ACEs study is that childhood adversity contributes to most of our major chronic health, mental health, including substance use and suicide, economic health, and social health issues. Now, here's a list. Normally, I break them down into different slides, but higher ACE scores have been linked to traditionally what we have termed mental health problems, such as depression, clinical anxiety, substance use, attention deficit, higher rates of suicide and suicide attempts, hospitalizations for mental health issues, increased odds of opioid use, and higher risk for drug overdose. So traditionally, we associate those traumatic things, right, with psychological disorders. But researchers didn't expect to find ACEs linked to what we traditionally thought of as physical chronic health diseases: COPD, obesity, cancer, heart disease, diabetes, asthma, stroke, and more. Somehow we thought this is just affecting the brain. It's not affecting the body. We were wrong. Higher ACE scores have been linked to, here was another surprise, negative social outcomes: higher rates of domestic violence, lower rates of marriage, higher rates of divorce, higher rates of school dropout, lower graduation and income rates, poverty, higher rates of unemployment, higher rates of problems on the job, and earlier initiation of sexual relations. Now, all of those lists I just went over are expensive. They're expensive in terms of what they cost families and the quality of life for our communities, but it's also expensive in our local, state, and county budgets. So I am so smart, and I was a drug and alcohol counselor, so I thought, well, people have had all that trauma, of course they're going to have higher rates of substance use, right? They're self-medicating. Ta-da! I've explained a big chunk of it, right? Here's what was shocking. Even with a higher ACE scores, even if there was no use of alcohol, tobacco, or other drugs, there was still significantly higher rates of chronic disease, including cancer, heart disease, and COPD. Because I thought, well, of course they're going to be more likely to have cancer, right? They're more likely to smoke, right? No. They're more likely to drink too much alcohol? No. Even if that was not in the picture at all, higher rates, significantly higher rates of chronic diseases. They did not expect to find that. You know, smart as I am, I just didn't get that right. So our tendency has been to ask, what's wrong with you? I mean, really? And truth be told, when I was a drug and alcohol counselor, most drug and alcohol counselors, not all, but many, I would say, have that issue as part of their past. And I was one who didn't. And so it's always been an ongoing journey to really understand it. And I have to tell you, there are a lot of times with my clients, I would kind of want to say this, what is wrong with you, when they couldn't get it, or just watching them destroy themselves. Yeah. But now that we understand more about ACEs, which we call probably one of the most important public health studies nobody knows about, it's important for us to try a perspective of compassion and curiosity. And so maybe here's the question we should be asking. What happened to you? What happened to you? Now, with that background and keeping that in mind, I kind of want to then make a jump to talking about the overdose crisis. The overdose situation in our communities is still listed by the federal government as a public health emergency. So COVID has kind of, in more ways than one, sucked all the oxygen out of the room. So they're sort of like, oh yeah, we have this overdose crisis, but we aren't really aware, many of us aren't, of what's going on or how we got here and how we can help. So here's how we have the overdose crisis. It's opioid-related overdoses, opioid-related overdose deaths, and a crisis spike in overdoses and deaths from all illicit drugs. And I'll get into that a little more. So I was trying to figure out a way to break this down better, and
I like a good chart.
Mari, yeah, this one doesn't have all the typos in it. The Board of Health meeting had about a gajillion the typos in it. I was like, oh gee, I guess I put that together quickly. So this isn't conducive to use, but it was, I just got the figures, that yellow line just yesterday in a meeting. So first of all, as you look at this, we've got the year, and then I will tell you, we've had the hardest time finding what numbers people talk about. You know, I'm actually kind of new in public health. I've used the public health model and treatment stuff, but to kind of look at it through that lens and really understanding, you have to have the numbers. What my brother is always saying is, now people in my department are quoting, as compared to what? So this is the way it is, as compared to what? So being able to look at things. So we've got the year now, and then, so we finally narrowed it. So people were collecting all kinds of data from different time, you know, like here's from August to September, or like, well, can we like have a measure like the time we get that? So we had to kind of go back and get it. So we finally, working with our local law enforcement, sort of boiled it down to 3 columns for now. First of all, dispatches, emergency dispatches involving a suspected overdose, where they get a call and someone says, hey, we think somebody's overdosed. Okay. The second one is where the officers have been trained and they can report, they're more likely to go, yeah, we're pretty sure this is an overdose because here's what was going on. They aren't 100% accurate, but it really narrows that to this probably was an overdose. And then the final column, sadly, is the deaths indicate cause from drug overdose. Now, some things to keep in mind as you look at these figures. Before 2020, our law enforcement did not even have a code for drug overdose. And finally, it was happening so often, they said, maybe we should have a code for this so we could start to measure it. So we don't know what was happening before then. There's also in that final column, there may be a lag in determination. COVID has still affected our medical examiner's ability to respond very promptly. And sometimes they go back and test things. And they go, oh, wait, it was this. And now we are beginning to find other drugs that they didn't test for, which changes some of the outcomes and stuff that we're trying to track. It doesn't indicate situations in the community where Narcan or naloxone, which I'll talk about in a minute, was used and nobody called the first responder. Right. So we have no way to track that at all. Right. And this doesn't include data from all communities in Boone County. It's information from the sheriff's department and from our local police department. That's all we have so far. We're working on getting county.
Can I ask you a question about your data? So if I called 911 in column 1 and said, I think somebody overdosed, and then the officer shows up and says, yes, I think it's an overdose, is that counted twice?
No, it's counted as a dispatch, and then it's counted in that second one. It stays with we lop off the ones where they go, no, it wasn't an overdose. So
it's a subset.
There we go. Thank you.
Subset
I talk a lot. I don't have course for math. Okay.
Yeah. No, that's right.
So that gives you an idea, and it seems as though things seem a little more stable now. For a while, they were just rising and rising. So to get the numbers to drop, I would say we have to start with stabilization. But alas, when we're talking about it, it's like, oh, our numbers are good. We only talk to the families if it was only 7. So, and again, I'll be happy for you to send the slides out. Also.
And it's only May.
And it's only May. So we may have done better. So this is just to give you an idea of, again, these graphs are a little more complicated, but synthetic opioids, other than methadone, and how that has just spiked dramatically. National drug-involved overdose deaths. This includes not just opioids, but also one of the interesting trends I frankly had not recognized was that stimulant use has continued to climb and climb and climb.
Is that like uppers?
Steady as she goes. Methamphetamine, cocaine, specifically. This has continued to climb. That has not abated. So, which I thought that had kind of settled down, like ecstasy or something, like kind of spike and then settle down. It's like, no, it's continuing.
I thought cocaine was. I've only ever even seen what maybe was cocaine.
Well, it's plant-based, so it's harder, and we'll go into that a little bit. So how did we get here? Well, first, in the 1980s, prescription drug makers flooded the market with prescription opioids, or synthetic opiates. Opioids are painkillers. Opiates are the plant-based, just so you know. And then so all opioids, I won't even go there. Anyway, so, but in reality, it's they're really very addictive. and overdose death rates and prescription spiked. And so long, about 2014, 2016, they made it harder to get those. This also began in about the 1980s. Seriously. You can trace it back to 4 sentences in an editorial piece in the Journal of the American Medical Association, where someone had written, and we've kind of tracked these and it looks like this isn't addictive, but more research is needed. And nobody bothered to look at that. It was an opinion, and pharmaceutical companies went, see, the journal said it's not addictive. And that's, that's sort of the holy grail. Everybody's looking for a painkiller that is not addictive. So seriously, this mess is from 4 sentences. So in reality, it's very addictive. Yes, and yes, exactly. Yeah. And then using that and saying, oh, they're having more pain, instead of it might have been pain from withdrawal. Well, then you can double the dose. So a lot of, okay, so then you have a lot of people who are going through withdrawal or dope sick. Now, I pause to say, opioids, I haven't been through it, but I had a lot of clients who did, and it was like the worst case of flu you can imagine. Everything hurts, diarrhea, sweats, and you just feel awful. You feel like you will die. Now, if you don't have other medical issues, you won't. It's not medically dangerous. This is just a little piece of information. One of the most medically dangerous drugs to withdraw from quickly, if you've used a lot of it, is alcohol. So that's why we have a detoxification center, so people can monitor heart rate and blood pressure. So a lot of people were like, well, then and if you had that worst case of the flu and you felt like you could just get a little bit of this, you'd feel okay, you could function, you could go to work, you could do what you need to do, you'd feel like yourself if you could have that little bit. So they turned to heroin. Now in 2007, this is one of the things, again, which convinces me you need to listen to preventionists, because I was at a conference with the National Guard, and they had a prevention unit, and they said, it was in 2007, and they said, we think we're seeing so many painkillers that we predict you're going to see a resurgence of heroin use, including needles. And we were like, no way. That's like so 1960s Vietnam thing. Like, no. They called it exactly. Just exactly right. So, and I'm a preventionist, but I listen to what my colleagues say on that, because they're looking farther down the road instead of just being reactive, thinking, knowing what we know about the way people use stuff, we think this is what will happen. So fentanyl was then imported from China in mass quantities. It was cheaper and easier to use than heroin, because heroin's plant-based. You need tons of stuff. When you do a synthetic in the lab, you could probably put a couple of bags behind the tail lights of your car and get enough to take out the city of Columbia. It's more potent and deadly, 10 to 50 times more potent than heroin. And dealers are selling and using fentanyl now. All overdose deaths in heroin 2021 were linked to fentanyl. There was no heroin. Our local law enforcement says there really isn't heroin. People might say, well, I use heroin. They're not. It's fentanyl. So the people who are selling drugs add that. It's cheaper. Hey, it's white powder. It goes with everything. And an average drug changes hands about 11 times a legal drug. So you don't know on that supply chain who's putting what in. There are also a dramatic increase in stimulant overdoses, incidents, and deaths like meth and cocaine. And as I said, law enforcement reports all varieties of drugs in Boone County are contaminated. They have found contaminated all varieties. That doesn't mean every batch they find, but every variety has been. So fentanyl and THC, that includes fentanyl and THC products, that includes vape pens and counterfeit or fake pills. Especially as a preventionist, is concerned about the counterfeit or fake pills, because there are a lot of people that aren't going to use a needle and they won't smoke. But a pill feels safe and effective. I heard of an incident in which 3 high school students split one counterfeit pill. 2 died. We're especially concerned about our teens who can order this online and have it delivered to their doors at 2:30 in the morning. also concerned that because of stimulants, we know college age young people, especially next to alcohol, abuse or misuse stimulants the most. So we're especially concerned about population. So can you tell one from the other, which is a real Adderall and which is fake? And I know on our board of health, we have a pharmacist who says, be hard pressed. Top one's Adderall, just in case. And the second one, this particular one is seized by the DEA, is laced with meth. So this is how much fentanyl it takes. When we think of overdose, we think of a lot, although the overdose is just too much. So it's really about 10 to 15 grains, the size of about 10 to 15 grains of salt, or the weight of one spoonful. Wow. So when I'm speaking to groups where they're eating lunch, I have them sprinkle a little salt on the table, say, try counting out 10 grains. The folks who sell it aren't pharmacists. And it's kind of like the chocolate chip cookie. You don't get the same number of chocolate chips in each bite, right? So
I think this is the most interesting slide that you have.
I think so.
Because it really gives you something that you can compare. And it's certainly a small amount.
Especially when you realize it's human error.
Right.
The dealers probably aren't even meaning to kill people.
Right.
Just they're careless and they're counting. Maybe they're on drugs themselves and not clear-headed when they're counting out the 10 grains instead of 15.
Yeah. Well, and also, again, factor in people's tolerance. If people who've been using, they have a tolerance, but another person, and then we know some of the most vulnerable people in our population, in our communities, are people who are recently incarcerated. Even for a few days, your tolerance level plummets. So they may be in jail for a few days.
Oh, that's interesting.
And come out, think they can use the same amount.
And then they may get happening, and I always wondered, how do you?
And then also people coming out of treatment, sadly. This is a chronic brain issue. This is a chronic brain issue. This is a chronic brain issue, folks. You need your brain to change your behavior. And so guess what? Know anybody got their high blood pressure or the diabetes under control the very first time? You might like go, okay, that wasn't a good idea to eat that peach cobbler. So, or whatever it is. So our neighbors who use drugs are also at the mercy of that sort of thing, only they're trying to change their behavior when the brain it's not working properly. So if they've been in treatment, maybe they're in treatment or in recovery, and they may go back to using it again, not having the idea or not understand it's that much more powerful. So this much also. So.
Is that on a pencil?
Yeah, that's on a pencil. Oops, sorry.
Here we go. Glad you knew how to do that.
Well, even this time of year, I have allergies really bad. I'm taking a Claritin, and the Claritin, I just look at that and I go, that's like just barely this teeny tiny little pill, and I think that has the capacity to regulate my body to deal with that pollen for 24 hours.
I had the same
I shouldn't be shocked that this is all it would take to do some really serious damage, at least. How many, either any of you or you know someone who's lost a loved one to overdose death? And Tim and I lost a first cousin, and it was 2007. She put on a second patch, painkiller patch, after it was prescribed, but after surgery. And we think she woke up and she was disoriented and put the second one on, didn't make the first one. So before we play the blame game, remember ACES? We want to go back to that. People with a score of 5 or higher are 7 to 10 times more likely to use illegal drugs and develop a substance use disorder. So, and what's in the drugs? Remember, fentanyl's in most of the drugs being used now.
Even the legitimate drugs? Or are you talking about illegal?
Street drugs.
Okay.
Yeah, street drugs.
And marijuana with low fentanyl.
They keep hearing mixed reports that the ignition temperature would burn off the fentanyl, but certainly THC products. And we've had some people say, I just smoked marijuana, and they ended up with an overdose. So we're still exploring that. But I wouldn't, again, it keeps changing hands, and people are trying to figure out, the same way salt, fat, and sugar in those restaurants, like we want you to like our brand better. So you'll come back to Red Lobster or Wendy's.
Put a little MSG in there.
Put a little extra fentanyl in there. So I don't know. And it's cheap. So
if you were using marijuana, if you were getting things from a licensed dispensary, you'd be a lot safer, correct? Because that's more regulated.
True.
Or growing your own.
Or growing your own.
And
where exactly where it came from.
The as far as the black market is still alive and well.
Oh, yeah.
So we've heard from law enforcement, which are like, dang, I just don't do that criminal thinking.
Yeah.
You get your dispensary package and then you put the stuff you buy on the street in the package and if anybody questions it. So people are still looking for a way to buy it cheaper. So if they wanted to be safer, but they are, yeah, anyway. So addiction, so I like this quote, addiction shouldn't be called addiction. It should be called ritualized compulsive comfort seeking. Again, if we think about the ACEs and what we know about how that affects people, people will walk around with a sticker on their forehead explaining these are the traumatic things. Remember the level of trauma going through those 10 questions. And when I used to work in drug and alcohol counseling, I would present this to folks. And I would say, now, this stuff happens before the age of 10. My ACE score is a 1. And most of the clients, 8, 9, 10. And I said, what did I deserve to have an ACE score of 1? And they said, nothing. Privilege. What did you do? Yeah, because it was low. What did you do to deserve an ACE score of 8 or 9 or 10? Nothing. So again, that's the blame game. We've got to figure out other ways to approach this. So why do people use drugs? I had somebody in Sunday school ask this. I was thinking, I have explained this to you about 3 times. But anyway, pain, physical or emotional. That's it. And reinforcers, I'll talk to you about that in a minute. So whatever brings relief to pain quickly has an addictive quality to it. Now, Anne, if you would turn off the lights just real quickly. And where's the camera that they're going to see?
You want them to see? Okay,
Yeah, I want them to see just
I'm
real
going to
quickly.
do this.
I think it's
stop
right
share right here. And then when you're ready to go back to the left, start share again. There you go.
So, all right. This is a candle. It works better if it's really dark. It's not really dark. But imagine you're a teenager and you're trying to decide what behaviors you should repeat. Yeah, he's gonna. Thanks. Yeah, hang on. We can get a little.
Yeah, that's gonna help a lot.
Yeah, that'll help a little. I think the computer, except the computer's like, well,
yeah, it's on the other side. I think you're okay.
That helps.
Yep.
But so imagine that there are things, it's a dark horizon, and there'll be things that to get your attention. Should I try this? Should I try that? Should I try forming a band? Should I go out for track? Should I talk to that cute person across the room? Should I help with chores? Should I get a job? Behaviors. So when we have there's a reinforcer in our brain, we solve problems. This is the primitive 10,000-year-old brain. Then there's a light. There's a light in the brain, all right? So you go, oh, I think I'll try doing that again. That's kind of cool. So here's what happens if you two would pick up your rattles. Here's what happens. All right, go. Whee! That's what happens on the brain of an adolescent. And this dorky little candle, if you can see that, it can't compete with that. So if you were here in person, you could see there's all kinds of colors and lights. Pull it back a little farther from the camera and see if they can see that a little bit more. Yeah, it just doesn't see it, but it's brighter. Okay, so you get the idea from that. All right, let me go back to here.
Let's see. I think if you grab the mouse, where's that? Yeah, there we go. Yep. Yeah. Take a spot.
Hers too.
All right. And you got to do share. It's like thinking of mine, though.
Yeah.
So, all right. Thank you. All right. You turn the lights on, Ann. Thank you. All right. So, when you have a teenager who's in physical pain or emotional pain, and again, they may not know it's emotional pain, right? They think everybody's life is like that. And that 16-year-old experiences alcohol. Hey, this is maybe the answer. Experiences cannabis. Hey, that takes care of it. So a 15-year-old who experiments with alcohol is 5 times more likely to develop an alcohol use disorder because of those immature brains and the way. Norma BoCo, director of the National Institute on Drug Abuse, has described it like an atomic bomb going off in the brain of a teenager when we introduce the underage brains to these substances. Again, you may have had, my clients would always say, well, they had fermented fruit. And I would say, yeah, but you couldn't pick up a 12-pack of fermented fruit every night on the way home. They might have experienced alcohol and went, well, that was interesting, but they couldn't do it over and over and over. So, okay, why is this not?
About my day forward.
Oh, because I was pushing, it's not wanting to go forward to do that.
Sharing.
There we go. All right. So it's, again, instead of saying what's wrong with you, so you say what happened to you. So
I
further
love that.
reading, if you're interested, the book What Happened to You by Bruce Perry. I just finished an audio version. It's kind of nice. Dr. Perry and Oprah having a conversation back and forth, very listenable. And this will just, I mean, I was already pretty passionate about this, but now I was like, oh my gosh, there's still so much more. So if you're interested, the book What Happened to You, Conversations on Trauma, Resilience, and Healing, I highly recommend that. And if you're not into that, you can find, just Google Oprah Winfrey and Dr. Bruce Perry in conversation. You could find something that would get you acquainted with some of these concepts, podcast or video. So here's a map of our community. Again, this is May 2021 to April 2022. So again, that like this bizarre, like May to April, okay, in the middle of the year. Measuring stuff. Okay, well, there it is. And some of those, there's more than what is, you can see, because there might be more than one overdose on that location. But that gives you an idea that there's some where it's more than others, obviously more concentrated, but it's all over. It's not just one neighborhood. The overdose by type of visits, I'm going to move through this. Firefighters are most often our first responders, and firefighters are 8 times more likely to be answering a call for an overdose rather than fire. Now that's the national average, and I asked our fire responders, and they said, yeah, that's about right. Yeah, 8 times. So if you see a fire engine, it's more likely a drug overdose. If you see a fire engine, it is more likely a drug overdose. I'd like you to remember that as you see fire engines in the community. So signs of an overdose, I'm going to go through this quickly. The person isn't moving. The breathing, here's the key thing. The breathing will be slow or absent. The person may be sort of choking. You can hear gurgling or snoring sounds. The skin will feel cold and clammy. Pupils are tiny. Lips and nails are blue or ashen or gray if they're African American or a person of color, and you can't wake them up. So usually, even if a person's intoxicated, you kind of shake it like, okay, nothing. And the reason is because it affects the lungs first, and they're suffocating. So call 911. That's the main thing, is call 911, and then you administer naloxone. I'm not going to do a whole training, but I'll tell you how you can get a training.
Do you want them to see you?
Yeah, I want them to see me. I'll tell you what, let's keep going.
Sorry,
let's
I
keep
just
going,
triggered you.
and I'll come back to that at the end of the time. I want to
That's
time
you
for
up. There
questions.
you go.
So, but I'll show you. But we have the spray, and so the spray looks like this. I can show you kind of a model. You guys can pass it to me. You get an idea of what it might feel like. So suffocation, it stops the lungs from working, and it saves lives. So in a flood, the first thing we do is rescue people, all right? I feel like it's done for hop in a boat people and rescue somebody. Later, we will talk about more effective flood control, and we need to, but we have to be rescuing people. Naloxone or Narcan right now is our rescue tool. So these first responders carry naloxone. Columbia Police Department, Boone County firefighters, medical first responders, and I have an updated list to say also campus police. I think all the campus police at all the institutions of higher education I need to update. So, and then there's a standing order from the governor that all citizens can purchase naloxone without a prescription. You still have to go to a pharmacy. It will be over the counter eventually. We think it's FDA approved, but that's going to be some months, and we don't, just the bottom line, we don't know how that will affect things.
How expensive is it?
I paid $10 with generic as a city employee last summer, but it depends on your insurance.
Well,
So if I wanted to have some in the cabinet, just as an
I
emergency,
carry some in my purse. Yes,
Okay.
I carry some
and
in
it's
my
a
purse.
$10 investment, and maybe
It
saving
depends
somebody's
on
life.
your insurance and
Oh,
pharmacy.
Okay.
It may be $50. It
Oh,
may be
my.
$100. I don't
But
know.
worth asking.
You can go ask.
Does it have a decent shelf life?
I think about 2.5 years, but it has an expiration date on it, and you could still use it.
you have to get a prescription from your doctor.
No,
You don't need a
that's
prescription.
the weird thing.
You just need to buy it from a pharmacist.
You have to buy it from a pharmacist, but you don't need a prescription. And I would call your pharmacy to see if they're participating, because
Okay.
some pharmacies just don't want to mess with it.
No. Okay.
So no, we don't want to be part of that. That's what we were told. So how else can you be part of the solution? We have trainings where you as a citizen, can get your own 2-dose box of Narcan to learn how to use it effectively to save a life. The main thing is call 911 because you won't remember what I tell you anyway, but call 911.
Maybe talk
And if
you
you have an
through it.
RPN, they'll talk you through. So, but we're having on 17th at the health department, we're having a live training, noon hour, drop in, get trained. And then also, actually, it happens to be my church, Broadway Christian Church, is having another one on May 24th in the evening, and that's open. There's no registration. It's open. So if you need more information, there it is. I have a request. If you would raise your hand, if you will. Within the next 48 hours, share the information about what are ACEs and why should we care. Share that with at least one other person. Because I remember where I was at what conference, where I was in the room when I heard about ACEs, and I thought, what? This is it. This is the bottom of the barrel. What? Because I wonder why people do this. And then I came back to Phoenix programs and I asked my colleagues, I said, do you guys do anything with ACEs? And they're like, what? The people who should know, really people. So we're learning more, but I'd be happy to send you a copy of the PowerPoint. And what was your name again?
Sarah.
Sarah will send you a copy of the PowerPoint. Yep. So if you have questions or feedback. Usually I did surveys, but I couldn't find it on my computer. All right. Great. So yeah, great. All right. Time for questions. Thank you.
There was one of your slides earlier, just after you were talking about the 10 different.
The ACEs?
Yeah, the ACE category thing. And you said people who have one or more have to have 2 or 3, but then immediately after that it said something about 4. And I lost me on that. Why?
When we see 4, there's a much higher likelihood they're going to be negative outcomes. So a lot of people have 1 or 2 or 3 or 4, and they deal with it. And somehow there's still enough supports going on.
Yeah.
But when we start seeing 4 and more, then the levels of alcohol misuse, for example, or just a lot of things begin to go a lot higher. And I kept seeing information on raising resilient children. We see that a lot. Let's raise resiliency.
That word, yeah.
They don't tell you the reason they're using that word is because what they learned in the ACEs study. They don't say it's because of this list. And so when I started going around to civic groups, I said, I want to read that list because we go trauma, yeah, trauma. Okay, yeah, bad things, yeah. But when you hear that list and you go, can you imagine a 6-year-old having to deal with 3 or 4 or 5 of these at one time and then going to school and trying to listen? It's maybe not the ADHD, it may be trauma, folks. And and yet we have the system that punishes a child if they can't pay attention, yet maybe they saw their mom beat up last night. So I don't have all the answers, but again, we need to be asking more questions as to how we help kids and help sooner. And some of it's going to be going farther upstream to prevent the ACEs. And even if we can't do that, prevent underage people getting access to addictive substances.
I didn't realize that. That's something big that I learned today was, just a little experimentation under a certain age is not okay.
It is
like
not.
I would have been too
It
stressed if I found out my kids had experimented a little. They haven't so far that I know of. But I wouldn't have freaked out as badly as I might freak out now if I find out that they have a joint or a beer can in their room or something.
And again, people think prevention is just say no or dare. Those are 40-year-old sound bites.
Yeah.
And we don't do treatment the same way we did 40 years ago. Trust me, we don't do prevention. Where do kids get drugs?
From their friends.
Where do the friends get it?
No, from the other friends.
Where do the friends get it?
I know.
From dealers.
I have no idea.
From adults. If you trace it back, any young person who has alcohol, tobacco, or other drugs, it's a controlled substance, they get it from an adult who will buy, supply, or won't lock up for them, or will sell it to them. Adults have created this environment, and we expect young people whose brains age appropriately, can't think past the end of their noses. That's developmentally appropriate. It's on us. Adults should be the ones saying, just say no. And then, we do all we can. And then when they become of age, the number of people that have a substance use disorder that started after the age of 21 is plummets. Plummets. 90% of substance use disorders begin before the age of 18. 90%. If I sat here and told you 90% of cancers begin before the age of 18, wouldn't you be paying attention to that? But there's no money in prevention. There's money in creating disease, and there's money in treating and managing it, but there's no money in preventing it. So,
We've got some good stuff in the chat. One's a comment. David Robinson says, is there a reason I did not hear the term harm reduction? Some people I know feature that concept in dealing with drug problems.
Exactly. And really the naloxone is a form of harm reduction. I will confess and be honest to you, I was a slow convert to harm reduction.
Really?
Yes. But when I began to see, oh, well, one statistic that sort of won me over very quickly was 100% of people who died in a choice
Yeah.
to choose a different life. And thinking of so many of my clients I saw get on their feet and live satisfying lives, getting jobs, paying taxes, taking care of their families.
Yeah.
So the other is, for example, people have to understand then, for example, people aren't always ready to change. So how can we meet them where they are to keep them alive until maybe they are, and maybe they won't be, I don't know. But we can't, if they have died, we cannot help them. And it's, again, it's very costly from a government standpoint, just even from a government standpoint, helping a family out when there's been a death like that in the family, but let alone dreams and families and communities and stuff. So harm reduction would be like safe, would be clean needles. Some places have syringe exchanges, etc. I won't go into the details of all that. We don't do syringe exchange because that's not legal in Missouri. But of meeting people where they are, and we don't leave them there. So the naloxone is a harm reduction strategy, but we have other ones that we're implementing. But thank you, appreciate you bringing that up.
Yeah, and Kathy points out in the
Yes.
chat, she says that this would be an excellent presentation for teachers, school counselors, principals, school resource officers, and the CPS superintendent. Just having more insight about the ACEs would help teachers.
I think they may have some,
Yeah.
but they're just overwhelmed with the scraping up the mess caused by ACEs.
Yeah.
The other thing, I had the privilege of being on a webinar a few days ago with judges and defenders. Yeah, public defenders. Thank you. Public defenders, and explaining more about the neurological changes in the brain. It's a physical change in the brain. Learning is a physical change in the brain. We think of it, I'd be like some esoteric cloud that settles around someone. It's a change. We now know it's a physical change in the brain. If I learn something new, my brain has physically changed. So if we think of that. So
and it's not, and again, this shift of, I've read that book, What Happened to You, the shift of thinking from, this is a bad person who's making stupid decisions and they need to just shape up. I mean, that's has been a traditional kind of the attitude,
you should
right?
just make up your
Pull
mind.
yourself up by your bootstraps. Just decide to be better. And there's a lot more to it than that, and a lot that was out of their control.
And in that
before
book, one of the
decisions
stories, so if you read it, you'll hear it, but the young man, trauma in his home, ended up in foster care, horrible foster care situation. He's in school and he just just blows up at the teacher. Nobody can understand what's going on. It's an awful mess, blah, blah, blah. And so the doctor talks to the father who has alcohol in his breath, but also apparently has used Old Spice to cover up the alcohol. And so the doctor talks to the teacher and says, do you use an aftershave? And the doctor said, yes. And he said, any chance well, what kind is it? Old Spice. The smell, but it was that deep in this child's mind. That child would not have understood. I can't remember how old he was, maybe 12, have gone, this is
a trigger.
It's so deep in his brain. So they had to, and then again, to be able to meet him there. And I was thinking about this, I watch all those cute videos on Facebook about rescuing dogs, and and they instinctively, people will sort of sit and earn the trust, and they don't go in, hey, you're a dog, it's safe now. We instinctively move in at the level that animal needs to begin to develop trust, pay attention, and then take them there. That's what we need to do with our children, but our system is more like, hey, it's safe now, you're good, and then somebody smells Old Spice and they go off, and we can't figure out why. So,
Pam asked if you could repeat the time of the naloxone training on 5/17.
Yes, 5/17. 5/17 is at the health department. That's actually over the noon hour. 12:15 to 1 o'clock. Health department, 1005 West Worley. 12:15 for 1 o'clock.
Do we need to sign up ahead of
Nope,
time?
you just show up. Just show up. That's right. No registration, neither of these. And the other is Broadway Christian Church. Wednesday evening, 24th. 5:30 to 6:15. I call it the on the way home because we know people, I don't know about you, the couch of gravity is a real force in here. So I just keep the momentum and stop in and go, okay, then I go home and then I'm dead. So, okay.
This has been great. What other questions do we have? Mari's got a question.
Yes.
My question has to do with the inadequacy of our system in terms of having treatment opportunities for people and a good way to connect people to those treatment opportunities, especially inmates who are coming out of prison or jail. And so my question is, what do you have ideas about what could be done to address that? Is it a supply problem in terms of people not wanting to go into these fields anymore? Or is it
It's complex.
Yeah.
When I talked to Holly Ryder back before the end of the year, who's in our Missouri State Senate, and she said, well, people don't really want to go into the fields. I will also say, I noticed there was a study in the state of Washington where the average social worker, licensed clinical social worker, was earning $40,000 a year for a job that requires a master's.
Mm-hmm. An incredible demand.
Right. And yeah, and I know of one licensed clinical social worker who was in private practice who said the university several years ago was offering this person the same thing they'd offered 25 years ago as far as cocaine. So we aren't keeping up with the cost. We aren't paying. Missouri is at one time, according to I think a Kaiser Family Foundation study, we were 51st and having the correct number. Puerto Rico was ahead of us.
Oh my goodness.
I used to get up and thank God for Mississippi because Missouri wasn't last, but that's not good anymore. But for having the right number of mental health providers.
Yeah.
The other thing is also to understand that if you have a mental health provider or any kind of health provider, really in Missouri, do they want to live in Maryville? Do they want to live in the Boot Heel? They want to live in Kansas City, St. Louis, Columbia, or Springfield. So you have a lot of desert areas out there, if you will.
Mm-hmm.
So I don't, telehealth has helped a little bit, but there are a lot of people. I remember when I used to work with one pediatrician who would say, you have to remember, I have patients who have to go out on the front porch to get a strong enough signal to call to make an appointment.
Mm-hmm.
They're not going to, telehealth is not going to help them.
Right.
So those are questions we need to address. And I still think part of it is people are not getting paid enough for them to want to go into those fields. How we address that, I don't know. But I suspect, as with there is money in creating diseases and there's some money in managing it. And if we follow the money, there will be some explanations, I think, as to why people don't want to go into it. I can't answer all of it. My passion, one of the things I care about a lot then is also equipping families to help more. Families need not just support, but in my estimation, coping skills, not just, yep, yeah, you're having a hard time. So they can stay engaged longer instead of like, I've had it, I'm done. I'm done with this. Versus they can stay engaged longer, they can invest in the relationships. There are ways they can do that. But most of us, it's all or nothing. It's tough love, and they don't understand other ways. So we do have a program that the health department that I work with called School of Hard Talks.
Mm-hmm.
We just finished for the school year, but we'll start up again in the fall. But it's specifically for parents of teens or parents or loved ones who have adult children with mental health and or substance use issues. We're trying to invest in the relationship, improve communication skills. Because to consider change, people want to feel understood, confident, and in control. And that's usually not what we're encouraging when our family members have an issue. So they might be able to exert more influence. They won't exert control, but to family members, because they are on the front lines. If we're not going to get enough professionals, can we start training more family members? Training. Yeah.
Yes, I would also comment that we see.
Thanks, Ann.
Hi.
Little Ann.
That's what she was calling earlier. You've known her 7 years. Hi.
I would also comment that it seems like one thing I learned in looking at this issue at the request of the county commission, the Board of Health has kind of studied where the gaps are in our local system. And I guess I did not realize how many tries it takes for some people to get away from this. And talking to the head of a local nonprofit who works in this area, he said that he had been a substance user and that he had on his 14th time he was able to
It seems to have
stay
stuck.
clean.
Yeah.
And so, given that it takes just an incredible amount, apparently, at least for some people, of not only treatment, but peer support, that was one of the big gaps that we identified that we're emphasizing for the use of the opioid settlement funds, because both the drug court and Into Action, which works with inmates coming out, they both use peer support, and that seems like such a positive loop, because that means that people who have gotten through their addiction are being paid to help other people who are going through that process.
And one thing then for community members to keep in mind is your event recovery friendly?
Yeah.
Because we're only serving alcohol. I had a lot of clients who say alcohol is not my drug of choice. However, a couple of beers into the evening, suddenly using meth sounds good again.
Yeah.
So for us to be more active as a community about providing opportunities to socialize where it's a safe environment. I know of one person who said my church had a welcome the pastor, and it was not at the church, and so they went and said, here we go, if you have some, you can have soda, you can have some wine. And suddenly for that person in recovery, it was no longer a safe place. And they had expected, it wasn't at the church because they don't have it, but they were expecting because it was church related. So us to think about, I went to a party once where they had, I walked it off 6 feet of alcoholic beverages.
Oh, wow.
And there was water and Coca-Cola. That was it. And it wasn't because anybody was being mean. It's just like they never thought there might be someone who wouldn't drink. So for us to have that in mind as we're planning events, do I have to have alcohol? Could I do a brunch and maybe just not have any alcohol, to do that? And for sure have non-alcoholic options and make the activity more about the activity, not the beverages.
Let me throw out some of the stuff in the chat, and then I'm going to call on
please
Pam and try to unplug and let you hear her. David Robinson notes, mental health and addiction are big topics, really all consuming. Too many people want to deal with them by employing denial or maybe simple solutions or blaming. That's real simple, right? And then Dave Taylor asks, what Mari said made me think of this, his comment, are there any teens or other young people doing these presentations at schools for their own peers? Sometimes hearing it from someone close to one's own age makes it seem more real.
I don't think so. They could be. The challenge with that is, number one, then teens often have a high rate of relapse or using again. Number two, then we're putting the onus on the teens instead of my patient. I want to get out there and help the parents understand more. So yes, that can help. And that's a good approach, and we have to be much more savvy. Like I do not use this light presentation when I'm talking to teenagers because they hear the word reward or pleasure. They don't care if you say it can kill you. All they hear is that positive. That's age appropriate. So how we word that. So sometimes teens could, but it's difficult to find a way to do it in schools except evidence-based curriculums, which usually take a lot of training, a lot of time, and are expensive and need to be incorporated into the curriculum more than 1 year to do any good at all.
Okay, I'm going to put my headphones and then you should be able to hear Pam. Pam, go right ahead.
Yes, I'd like you to comment on social media and what that factor.
I think that factors, I would say that's probably another atomic bomb for our teens, for all of us, really. Again, if you think of it like the 10,000-year-old brain, to have something that pulls us in, that's structured, that's made to pull us in and keep us in. So the same thing with salt, fat, and sugar. Same thing with process addictions like gambling or screens or shopping. they're different. It's a different brain reward, and our brains are not made to accommodate rewards that are that big, that keep us engaged. And screens is just another one. Also, the fact that the social media, then the kids have, it's hard for them to be present with families when families could be, for some, a positive influence. It's hard for them to be present, and when their parents are on the phone too. You know, go to a park and you will see, watch me, mommy. And mommy's like, yeah, on the phone. Watch me, daddy. Yeah. So they're not getting eye contact. They need our attention. And it's difficult. I know last time I visited my granddaughter, I just thought, I'm leaving my phone downstairs because I would take it with me, and I wasn't focusing on her. So that's an excellent point. And when we wonder why kids are having such a hard time, think about what it was like growing up, what you ate, we did chores, how your family interacted, how often did your family eat together? You know, our family ate together most nights. It was a big deal when somebody got a job and they weren't there for supper, or Tim was a track or football practice or something. But we had supper together, and that's a big protective factor for kids, is to have that sort of check-in time. When people don't do that, it's fast food.
But I would think that families where all this is happening would not be
Doing any of that.
necessarily conducive.
No. And then, yeah, if you have those higher ACES scores, it's just an environment where everybody's struggling. So really to go farther upstream, if you will, to help prevent, to go to this level, to prevent ACEs. But again, what's doable? One of my patients has been, you got two 16-year-olds standing in front of you. Which one of those has had trauma? Okay, you have no trauma and you have an 8. They don't come with a sticker that says you should not give me any addictive substances because I will be much higher risk. They don't come with that. And then also people will talk about children, people being predisposed. Well, I struggled to figure out what that meant. So finally, this is the story I made up to explain it to myself. You have two identical twins, or identical twins, who were born into the Orthodox Jewish community. All right. So my understanding is they use alcohol, but it's not acceptable to get drunk a lot. So they might use it occasionally, but it's not all the time. So you have one, they turn 18, they're exactly the same genetically. One stays with the family to help with the family business. The other goes to college in Columbia with the Tigers, where we start drinking on Thursday nights. Who's at higher risk for an alcohol use disorder? The one who's in the environment, who's creating the environment. So it's about managing the environment in which they're making the decision. And so when they're home, if that young person got intoxicated a lot, they'd probably get a scolding, and it would not be, this is not acceptable, we won't do this.
Social pressure.
And here it's like, how come you're not? We start on Thursday. What? Come on, start early this week, Wednesday. In 2017, Columbia was designated the drunkest city in the state. People just laughed about it. Of course, we got all these students. Yeah, 25%, according to their statistics from their own surveys, 25% of the MU students don't drink at all. But we don't hear about that. See, so there are people who don't drink, and we're pretending everybody does. So any more questions? I could go on, as you can tell.
No, this has been great.
Okay.
And then we've recorded it too. And
Okay.
people do come to the website and watch it after the fact. So
Okay,
this will continue
great.
to have reach.
Well, feel
beyond
free to reach out if you have
10 minutes.
questions. Again, we're going to start up the School of Hard Knocks for family members.
Great.
If they want to learn to communicate better with someone, with a loved one who has substance use or mental health issues, we'd be happy to help with that. We're going to be starting up again in the fall. But there's an online version. Actually, if you're interested in that, I can still send you that online version information. It's the feedback we've gotten from the pre and post surveys has really been helpful for people.
And your information, your contact information.
Yes.
That's in the slides that are going to be passed around.
Yes.
Okay.
And then you can just call the health department. I also have cards.
I didn't realize the city and the county had one health department. I thought they were two separate.
No, it's a model, I think.
Is that new, or has it been that way for 30 years?
It's been that way for a long time. Thank you.
I don't know if anybody else, does it.
Yes, but I don't know who.
Okay. I'll take a note.
Yeah. She knows how to get hold of me.
Yeah, that's right. I
Yeah.
figured she probably. would
About
do
15 ways, I think.
that.
More than she wants, I suspect.
I was impressed with the fact how fast the tolerance levels dropped. I had no
3
idea.
days, I think, yeah. It's very.
That could just be a dry
And so
spell. You ran out
the
of money.
most,
Right,
those are the
right.
most, and our homeless, our unsheltered neighbors, I'm working on my lingo. Our unsheltered neighbors are also very at risk, because guess what? There's a lot of pain. Guess what?
Yeah, they have a lot of this.
Very high. So people think, oh, well, that, it's just what happened before that person got there. A heck of a lot of them. And when I've worked with unsheltered neighbors, and a lot of it is, it's hard to follow rules. You can't make a lot of noise. You have to do this. You have to, it's just follow rules. You hold down a job because you have to show up, or you have to get along with people, or whatever it is that you need to do. And there's too many other things going on. So I don't have answers. I have a lot of questions. So thanks.
Thank you so much.
Yeah.
Yeah, this has been so great.
Sure. Thanks for inviting me.
Yeah, thanks for coming. So at this point, we're going to move on to our regular meeting.